Great.
Boa noite.
Good evening, everyone. Welcome to one more webinar of the BJAN, second webinar for 2024. This webinar, certain way, is the follow-up sequel of the last webinar about control of difficult airways. Well, it was published, two papers were published actually that approach the matter of control of difficult airways in adults and in pediatrics. So in last month's webinar, we had the revision.
Recomendações para o controle da via difícil no adulto e no mês atual faremos a abordagem do controle.
So we will have the approach now of the difficult airway control pediatrics. Last webinar was a success. It was very watched. There was a large amount of people watching. And we also saw in the rate of accesses, more than 7,000 accesses on the English version and about 4,500 in the Portuguese version, showing how important it is and the interest that this brings to our anesthesiologists and other doctors when it comes to the control of difficult airways. So without further delays, I would like to pass the word to Professor Norma Sueli, the specialist when it comes to surgery and anesthesiology, the State University of São Paulo. And Dr. Norma, she's already a long-term member of the publication. She's been contributing with her articles. She was the co-editor of BJAN and the current associate editor for the Brazilian Journal. So please, Dr. Norma, you can go ahead. Thank you, Andre. I wanted to thank this invitation to be able to have this webinar and thank everyone. I can see that we already have 46 participants in this meeting. I just wanted to tell you a bit about how the idea came up for this specific subject matter, which was published in January in the BJAN, in the Brazilian Journal. And I think that it's a subject that for anesthesiologists is the big challenge for anesthesiologists, the biggest challenge. The subject came up when the SBA, when they were still part of the Permanent Education Committee. It was requested to Abel. He was the president of the commission at that time. They asked him for some guidelines. So at the end, we thought it would be better if we follow through this rigid guideline methodology. So we went to, not that, we went to recommendations. So that's how the idea came up for airways, thinking about this. This has been more than 2 years since we started this work. So to set up the team, if you take a look at the authors, these are the people that really like pediatric anesthesia. They really focus on it. They spread information. They have classes. They have also practical work when it comes to, well, APD, the SAP. These are the spread of the practical side of things, not just the theory for pediatric anesthesia. On top of everything, you're big trainers, the trained anesthesiologists. So on top of everything that we've had in a few centers, the specialization of R4 and pediatric anesthesia is very good. So this has been a great team. It's been very well done work. So folks really got excited and they were part of it. So we would also like to thank SBA for giving us this opportunity, spreading this work, and BJAN. So our goal was that to spread, especially mainly for Brazilian anesthesiologists. BJAN, we know, is the widest reaching publication in Brazil. So I think the work was done, it was finished, the publication came out in January. and I thought it was very good. Yeah, well, forgive me, but well, it wasn't just my work, it was big group project. It was very nice participation from everybody on these recommendations. So I'm gonna pass the word to Dr. Débora. I'll present Dr. Débora.
Eu falo que a Débora, ela
I say
dispensa
that Débora needs no introductions, but Dr. Débora, she is specialized in pediatric anesthesia. She worked on Little Prince Hospital, a master's and a PhD for the University of Medical Science in Santa Casa, São Paulo, MBA in health through Einstein College Hospital, and she is with the SAP anesthesia service, and she works in the Chief Hospital Sabadell and the Municipal Childhood Hospital Menino Jesus. So Débora, she will now show us this work. So Débora, thank you very much. I'm the one that is thankful, Professor. I'm thankful to the SBA and to the BJAN, Andre. It's a pleasure, it's an honor to be able to spread information about pediatric anesthesia, because we know that this segment of the populace, sometimes there's not a lot of evidence for them. So when we can do work, yeah, it's all off label. It's all off label, you know? Yeah. So we can do good work. We usually become quite proud. I want to congratulate the SBA for the initiative. I'd like to have sharing the screen. I'll share the screen here. Can you see? Yes, it worked. It did work. Well, when we work, think about pediatric airways. It's very different from adults. Situation is quite different from children and adults. So for this recommendation, I have a rationale so that this will facilitate the decision making whether it's prior early intervention or not in a child. So due to all the characteristics that the children have, we know that the intervention, unexpected intervention, has a lesser incidence on adults. When we think about newborns and kids that are still breastfeeding, they're different from the older kids. And this range of age, we find a higher incidence of difficult intubation, difficult anticipated difficult airway is not always and cannot always be anticipated because we can't identify risk factors for this difficult airway in this age group. And due to their physical characteristics, these kids show a higher incidence of hypoxemia associated to tracheal intubation. So this is a very important paper in pediatric anesthesia. It's nectar brings in a few very important reflections for us. It calls attention to the fact that this newborn population, they included kids below 60 weeks of age, post or so. It calls attention that these physical characteristics, anatomic and physiological characteristics, coming from their development, especially the cranium and the airway, the lower airway itself, it takes us towards more difficulties when it comes to the access to the airway and a lesser capacity for a safe apnea period, which brings us towards a difficult airway, difficult physiological airway, different from adults. It calls attention to the fact that these patients that were assessed in this study, despite most patients having a classification MAC 1 and 2, CORMAC 1 and 2, there's a high number of attempts, and it calls attention to the need of professional experience. They relate this higher amount of attempts a lot of times to the lack of experience in dealing with airways in this age group. 50% of the kids that have a CORMAC below 3, the most utilized study was a change of sheath and the use of the bougie, and they used at least 2 attempts for successful intubation, calling attention for these physiological differences in this population group. And what these authors bring as a point of reflection is that we must have more efforts towards reducing the amount of attempts for direct laryngoscopy in these kids, especially if we're going to be using video laryngoscopes and optic fiber. We must use apneic oxygenation to increase the safe apnea period in this age group, and there is an urgent need for the development of guidelines for this neonatal
dos anestesiologistas para o acesso da via aérea pediátrica. E aí fica como reflexão esse editorial.
So this editorial that I believe is great when we think about difficult airways. It's a point where we're going to change the paradigm when it comes to managing the pediatric airway. It's a lot more important than the device being used in intubation. It's more important target. But what we need to focus on is keeping oxygenation much more than an attempt for intubation at any cost. So, as a consideration for these recommendations, we look to organize these strategies for managing difficult airways in children, for revising literature, and the experience of this professional group that is involved, as Dr. Norma already said. The focus was to keep effective oxygenation on these kids much more than any attempt at intubation. Limit the amount of attempts because they lead us to serious complications with the goal of diminishing trauma. Quick transition towards care if there is a failed attempt. Handling a sequence of maneuvers support towards decision-making and the strategies in each phase. Reducing the cognitive load through a flowchart. This will help us as well in a quick manner to direct the strategy when there is an airway, and also to bring us reflection regarding human behavior, mainly when it relates to training for stressful situations. When we think about the construction of this recommendation, right, these guidelines, this paper says that we must open the box. For us to have guidelines, a recommendation that is widely acceptable, it must be simple, intuitive, easy to memorize, it must be practical, and it must be open, whether it is applicable and adaptable to several situations. So we know that that's how our country goes. It's a country that has several different realities. So we must include locations, resources, and the expertise of that place where we work to be able to apply these recommendations. When it comes to the anticipated difficult airway, we have real large studies in the pediatric populace that brings us important data. The PED, which is the Registry of Difficult Airways. It's an American study. It brings us, it assesses children below 18 years of age with an incidence of 0.2 to 0.5% of difficult intubation, seeing that 80% of these difficult airways are recognized with an incidence of 2% failure rate, but an incidence of complications 20%, and this includes serious complications. Another important study was Apricot, which also assesses a large amount of anesthesia in children below 15 years of age. It has a similar incidence of 0.28% of difficult intubation and 1% in children below 1 year of age, paying special attention to this specific age group for breastfeeding children. The risk of a serious adverse event was higher than 50% and with a failure rate of 0.08%. And this study that I already showed you, the reflections of Nectarine, which assesses almost 5,000 newborns below 60 weeks of age, of post-conception age, borns and breastfeeding children, it causes a lot of attention towards the difficult airways is almost 6%, seeing as 2/3 of them are not recognized, and 0.13% are situations where we have a difficulty in intubating, but also ventilating, what calls special attention to the risk of this population group, especially children below 60 weeks of age. So what are the predictors for anticipated difficult airway in children? On top of all these congenital anomalies that we know that is this genetic syndrome, acquired lesions that can generate retractions, tumors, cervical instability calls attention to professional difficulties, the need for trained professionals when it comes to accessing the pediatric airway. Another morphometric predictors, which are very important in pediatrics, restriction of the extension of the head, small submandibular anterior space, very important, especially for laryngoscopy, the size of the tongue, especially those syndromes that have a protrusion of the tongue, the craniofacial dimorphisms, and the lower inferior distances in the lip and the mouth. So this may be able to anticipate a difficult airway. So below 2 years of age, what have we seen? These predictors, so opening the ability to open the mouth, suprasenal or comiaxilla index, the cervical circumference, these are bad predictors. Good predictors in this age range below 2 years of age are predictors that are pretty generic. The age is below 6 months, weight below 5 kilos, and a height less than 61 centimeters. So a lot of the time, the examination of the airway does not give us the risk factors to be able to anticipate the situation in this age group. So this PED study, it brings us this incidence of 2 to 5 when it comes to the difficulty intubation every 1,000 attempts, with 80% of these difficult intubations being anticipated. And what the authors show us is that the success rate in a first attempt when you use direct laryngoscopy in these patients was only 3%. So, but this was the technique utilized on most kids. Around 46 of the times we use direct laryngoscopy. And when we notice the success rate for bronchoscopy and fibroscopy and video laryngoscopy, it was about 50% on the first attempt, but these strategies were less used, which is what Nectarine calls attention to, that we must also implement the utilization of these devices in pediatric practice. This other study that assesses and compares the usage of optic fiber to the supraglottic device with beta laryngoscopy, they assessed the difficult airway in 14 centers and the eventualities of hypoxia and adverse events relating to the number of attempts. And what the authors saw was that the performance of videoscopy through the supraglottic device when compared to laryngoscopy in terms of success to the first attempt around 50–60% on with these techniques, but fibroscopy through the supraglottic device on kids below a year of age was superior when compared to video laryngoscopy, with an incidence success rate 54% versus 36%. And the complication rate, both techniques were similar, but hypoxemia was lesser when they used optic fiber through the supraglottic device as a first attempt. Because with this technique, a lot of the time, we can offer oxygen through the supraglottic device, improving the apnea time for these patients. When it comes to video laryngoscopes, in the past few years, we've seen a boom in the amount of devices that are used in pediatrics and video laryngoscopy. It's important for us to understand that we have video laryngoscopes that are non-angled, that are similar to the standard laryngoscopy, and the hyper-angled ones, which are the devices that are arranged, especially so that there is a hyperangulation, but there is a better visualization. So a lot of the time, these non-angled ones, they can be used with a goal of teaching, so they can show conventional laryngoscopy, how it works. They can be used as a conventional laryngoscope, but the hyper-angled one, a lot of the time they have a better visualization, but a lot of the time there's a difficulty in progression of the tube. So sometimes you visualize the airway, but you have a hard time cannulating the trachea. And this is due to this hyperangulation. So there is a training method so that you use these techniques, but these are the most adequate ones in this population group that has a more difficult airway. So apneic oxygenation, what is recognized today is that we offer a oxygen source through the attempted laryngoscopy, especially on these kids that are below 1 year of age. These authors, they performed a study with the goal of generating oxygenation, nasal apneic oxygenation in kids that were intubated by inexperienced residents with the goal of promoting the interval of a laryngoscopy before the start of desaturation. They included kids from 10 months to 8 years and used the nasal cannula with a flow of 5 liters per minute. And when we see the chart, the patients that got their oxygen-free nasal, the nose rebreather, they have a much safer period than those that did not. So intubation more than 6 seconds for laryngoscopy makes it a lot safer at this moment of laryngoscopy, especially if we do not have the proficiency of doing this frequently. So what is suggested now in literature that neonatal children and still breastfeeding children, that we provide 2 ml per kilo per minute in this age range on kids that are higher than 6 to 10 liters per minute on the nose catheters. So if apneic oxygenation. Whenever we run into a difficult airway in pediatrics, the first thing in any recommendation is to get help. Preferably, we'll get help from the most experienced person. So an anticipated airway, the ideal thing is for us to be able to approach this patient, sometimes two anesthesiologists or anesthesiologists, that colleague that has the highest proficiency when it comes to difficult airways. So with our recommendations, we created this flip chart, as we call it, flow chart. And the recognized airway, and there it is, the first point is to get help. And before we assess the airway, we have this rational, analyze the predictors of difficult airway, the history of syndromes or malformations, and to assess if there is a mandibular retrograde mandible. So kids below 5 kilos and less than 6 months, you can recognize as a difficult airway. To examine the child and assess any condition that could make the intubation more difficult or ventilation. So having chosen the anesthesia technique, you can prioritize the technique that will maintain spontaneous ventilation, prioritizing oxygenation, be it through a nose catheter or a pharynx. Guarantee analgesia, tonus, and airway patents. And if the patient moves on to apnea, then you prioritize apneic oxygenation with a nose catheter or a trachea. And the provision identification of good visualization, we can consider the use of neuromuscular sedation to guarantee access to the airway and ventilation. Always avoid intermediate anesthesia plans. Always prefer the child to be more awake or more asleep to diminish complications such as larynx spasms. And the material we must have separated in our arsenal have the devices that we have available at our hospital and we are proficient in their use, be it a broncho fiber optic. If you are skilled with it, associate the supraglottic device and work on fiber within the device. It brings a safety to our procedure for the kid, and to use a video laryngoscope, the one that you are most experienced with. So this must be the initial approach. During the approach, use the first attempt. So the first attempt must prioritize good oxygenation, optimize the positioning of the children below 2 years of age, the sniff position, their mouth open, jaw thrust. So this brings the better possibility of ventilation in this populace and to prioritize the device and the most proficient technique on the first attempt. Use the best you have in the first attempt. So associate devices. A lot of the time we associate the bronchial fiber to optic fiber and limit your attempts. This is a very high point because we must limit the attempts at most 4 due to the risk of complications. And each attempt modify your strategy. Either we modify the operator or we modify the strategy. Remember to use a straight blade for kids below 2 years of age. Remember to modify the positioning so that we are successful. If it does not work, we must consider the use of neuromuscular blockers and consider rescue with the supraglottic device. Always preferring the devices with the intubation and that we also have in the pediatric population, and to limit the attempts of supraglottic at most 3 attempts. If it doesn't work, think about waking up the patient. Consider this hypothesis, revert medication, and wake the child up. And the non-recognized difficulty when this registering the PEDI, this is the most serious situation. And there are some factors which are independent risk factors for complication. These are more than 2 attempts, a weight below 10 kilos, the chin distance being short, and when you talk about a form of hydrogen-free or a failure in the first attempt, these 4 factors are considered to be the independent risk factors for complications. And we can see in this chart up to 2 attempts in intubation, we have an incidence of complications around 0.15, but according to the increase of attempts, we can see that every attempt that increases in 5 times the risk of complications. So it's very important to limit the laryngoscopy. Attempts on children. When we bring this analysis of anticipated difficult intubation and non-anticipated, we can observe that the success in both situations is high, around 99, 95%. A anticipated failure and a non-anticipated failure is higher. But when we observe the incidence of complications, it is much higher in the non-anticipated one. And for the serious events, around 6% of serious events in this populace being 6% involved with stoppage, and in the serious events, 22% on this non-anticipated populace, seeing as 15% involved towards hypoxemia. Remember that hypoxemia for a kid is very serious. It can move on to arrest. So it is a serious reflection of the experience and the approaches. So normally in these situations, a lot of the time in these surprise situations, it generates stress for the team. And a lot of the time, we do not have the most experienced person in the room, and the importance, once again, of the passive administration of oxygen. We can see that this is a frequent recommendation on pediatric population. When it comes to difficult ventilation with a mask on a child, this is the oldest article, but it has an incidence of 6.5% for difficult ventilation with a mask, and it calls attention that the ventilation with difficult mask is much more frequent in pediatrics than difficult intubation, and calls attention to the proficiency of these maneuver. What is important for being able to save these kids, and there is no relation between difficult intubation and difficult intubation with a mask. So this ventilation is especially for kids or anesthesiologists that work with kids. It's important for us to have the training for our residents, for our colleagues, and these authors, they bring these considerations that in general, anesthesiologists, they really like learn how to use different devices. We want to learn how to use the video, laryngoscope, the fibroscope, several devices, and the relation on a facial mask. It becomes a learning that comes together with macular intubation or the larynx mask, but we need to take time and we need to demonstrate how to perform the adequate maneuver to be able to have effective ventilation. And what this shows us, the authors classify in degrees the adequate mask ventilation, and it shows us that they have a plateau for the alveolar ventilation in the capnography curve. Degree B, there's no plateau, but it's above 10 millimeters. And then 0, it considers it inadequate. And within the maneuvers, the ventilation with 2 hands is the one that brings us to activity in the populace. So in a general manner of speaking, for us to position the airway with both hands, perform the maneuver, and fixate the mask. And this was going to give us the best ventilation performance. So it says that we really need to take care when it comes to teaching these maneuvers for the pediatric population. These are very important. So it brings us this project image. So position the child, turn around, you can see this position. We attach a mask to jaw thrust maneuver. We elevate the angle of the mandible of the jaw with our open mouth. Mask should go above the lips and it must rest on the chin part and the fingers. We keep it jaw thrust, the fingers up.
Submandibular anterior deve estar livre, porque essa musculatura só se desenvolve.
It only develops with phonation, so the space is very thin. It does not accommodate the tongue of the child, which is much larger and protrudes within the cavity, and we place our finger on the bony side, on this tissue part, which is very thin. It tends for us to throw the tongue on the palate, and it obstructs first. So the right maneuver for ventilation must be this one. So we must train, we must be proficient when we take care of children in this range. So this is the article that came out just now in 2023. It's not even our recommendations. It came out a little bit after it got ready. It brings us important data, and we end up considering other publications. So once again, the difficult ventilation on a mask has an incidence of 9% of children. Is much higher even than the incidence of 6% when it comes to difficult intubation on newborns. And this group here, there was an incidence of impossible ventilations with the mask. 70% of these kids were carrying genetic syndromes below 1 year of age, with a weight lesser than a 5th percentile or higher than 95%. So the extreme weight, so low weight, and the high weight of children. So this brings us important data that 34% of these patients were rescued with the larynx mask, and 71% of the patients with difficulty in ventilation, they had success with this mask larynx ventilation and the difficult ventilation group. And in the impossible group, 48%. So very important rescue on the larynx mask. And the neuromuscular blocks, it improved the usage of their not modified ventilation. A lot of the time it got worse. So we should think about the use of the blocker when it comes to difficult ventilation. The device for the larynx mask is recommended for the rescue. In these situations, preferably are the second generation ones that have that gastric aspiration channel, because it will allow them to empty the stomach, and the distension can be a factor as well that takes us towards the difficulty of ventilation for children. And the authors call attention to that the difficulty of ventilation and management, we must consider the anatomic mechanical causes relating to positioning, technique, to hypertrophy, regurgitation, the gastric extension, and relating to anesthesia and larynx spasms sometimes thorax rigidity, use of opioids and bronchospasms, and the treatment of these situations. That will explain a little bit better in our guidelines. In non-recognized situations, we can run into difficulties for ventilating or difficulty for intubating, and the difficulty to intubate and oxygenate, which is a situation that we do not want to reach. And all of them, first thing to do is get help. If I run into a difficulty to ventilate, non-anticipation, we must think first off, if there is an anatomic cause, the fall tongue hypertrophia, and prioritize oxygenation once again, positioning, adjust the face mask at the right side, and optimize the mask seal. If the child has a probe, if it stops the correct seal, we need to optimize the seal and perform maneuver likely open mouth. So detach the tongue from the top, the roof of the mouth, and newborns to be able to create the space so the air gets through. Consider nasal pharynx cannulas. So whenever possible, we can use that. Nose pharynx that are more treatable, and to treat gastric distension, remembering that ventilation for the child is very abdominal. So gastric distension will be a factor that will limit ventilation. So it's very important to observe this and to treat this. To exclude functional causes, muscular rigidity. So to prioritize, once again, oxygenation and positioning, and to aspirate secretions for the oral cavity, and to administer the drugs propofol and neuromuscular blockers if we have larynx spasms, and cerebrotrabal and adrenaline and if the diagnosis is bronchospasms. If these strategies do not work, we will consider the use of muscular sedatives and the rescue with the supraglottic, and this what we use with the aspiration channel at most 3 attempts. Rescue with intubation at most 4 attempts. If we, in this situation, if we do not manage to intubate, we will also optimize the next attempt. So the first attempt for intubation must always be the best attempt. So to prioritize, once again, ventilation and oxygenation, positioning, assess whether the anesthesia plan or relaxing is adequate to intubate a child without plans, without the right relaxing. Relaxing would generate more complications, and we can use the video laryngoscope if we are available, the one that will have the most proficiency, or if I tried a blade that is not the right one, we can change to most children above 2 years of age to a straight blade. And the bougie, the guide, to limit the attempts, as I said, at most 4. In every strategy, every attempt, we will modify the strategy, prioritizing using the strategies that we have most training with. If the intubation strategy does not work, once again, the muscle relaxant rescue with the supraglottic device. So the supraglottic device and the pediatric recommendations, they show up in every situation. Anticipated difficulties and non-anticipated difficulties, as well as intubation. It's very important that we have more than one kind of device with their kit, so that we have an aspiration channel and a different type that will allow us to have intubation through the device. So good that we have 2 different types of devices in our service, limiting 3 attempts. If it doesn't work, we'll try to revert medication and to wake up the child. And here we have a situation that we do not want to get to. This situation is a situation that we must avoid at all costs. The whole time we put them into recommendations, prioritizing ventilation and oxygenation, because we don't want to run into this situation. I did not intubate, I did not oxygenate, I have a hard time ventilating and oxygenating. Always keep the attempts and ventilation and oxygenation to consider to wake up the child and to revert medication. If this did not work, if my kid is unstable, desaturating with myocardia, we must consider to act from the surgeon, and this is very important because over the years, we anesthesiologists were trained to believe that in the no intubation, no ventilation situation, we should go to an emergency surgeon. What we notice in the pediatric situation is that we don't know the incidence of the situation. Don't intubate, I don't ventilate. It's a very rare event. And because it's a rare event, nobody has any experience with this situation. So this situation that we run into with the emergency surgical access, sure, it's a heroic attempt. We have no other choice. We're going to try frontal access, cervical access, child to ventilate, but we have no evidence of what the best technique is. If these are percutaneous techniques, if these are...
O importante é que a gente tenha o treinamento para resgatar a via aérea difícil antes de chegar...
Before we get to the situation, and we must limit all the attempts so we have no complications that will put us in this situation, what is a very high mortality situation. So this situation must be avoided at all costs. So one thing that we have a surgeon or a doctor, depending type of service, to be able to help out. And even the American Society, the ASA, that within, they recommend that within this crisis situations, it's important that we have training, not just on techniques, but also behavioral training. See that calling for help is a priority to anticipate and plan out. So with leadership, it's very important. Definition of functions, effective communication, it brings us that human resources and adverse and serious adverse events of difficult airways, 40% of the time, it depends on human failure. So we must also train our behavior. So when we run into a situation that's rough, we'll keep our focus, we'll keep a cool head. So be able to take the step-by-step procedure so that doesn't end up in a bad situation, no intubation, no ventilation. And today it's recognized that we use cognitive resources. What are those? Well, every human, when exposed to a stressful situation, a lot of the time they can have a hard time accessing cognitive resources that we have in mind. So those guidelines, that sequence of steps that I know, a lot of the time at that stressful moment, I may forget. So cognitive resources are these flip charts, these flow charts, guidelines that we must use during a crisis moment. Whenever when you have a stoppage, there's a person that is assessing the situation from the outside. In an air situation, an normal situation, same thing happens. We can have a person outside the situation looking at the guidelines, recommendations, telling us, hey, next step is this. Hey, the other step is that. So this will give us the possibility of not occurring, not coming to a mistaken diagnosis or a early and early diagnostics. So these resources bring us these possibilities so that we have safety in our management, our crisis management. It's very important to have this. The perioperatory survival chain, the safe journey of the patient, not just the safety checklist in our routine, our day-to-day routine, but implementing our service checklists for
e os manuais de emergência, e os protocolos, e as transferências de cuidados de forma adequada. E implementar
care transference in our practice the use of this cognitive aids, and mainly the use of discussion and briefing of the critical events. Today, we know that when we sit down and discuss a critical event seriously, we learn a lot more than if we were to study just the theory. So we must implement high amount of safety systems within the surgical environment to deal with these crisis situations, we must implement not just what we talk about proficiency in different techniques. We also must create a safety culture where we utilize behavioral strategies to be able to direct a crisis situation with safety for the pediatric population. Oh, that's what I wanted to say. I'm thankful for your time, for your attention, and I will stop the screen share. All right. So if you have your questions, you can place them in the Q&A. It'll be easier to have it on the chat box. There is one question here. Débora, well, the class was great, and that's what I see. Adults nowadays, okay, awake intubation. For kids, you can't do that. So instead of trying to intubate, the guideline shows us that, and those points they focus on a lot to offer oxygen. The deal is always oxygenate. You don't need to, but also always oxygenate. So it's very important. Call for help and to switch the device that you used or optimize. Sometimes you don't use the right device. Sometimes you're using the wrong blade. Always rescue the supraglottic. We think that this point here, it's discussed a lot, this type of approach, you know? So what do you think? So in pediatrics, with the internet of pediatrics, we have a very high lack of evidence, a robust base of evidence, and we're in favor of one strategy or another. So what we see today is that there's this attempt of diminishing the complication of desaturation and survive in a situation like this. I think that's the most important thing today, and all these publications call attention to avoiding these events, the serious events. You don't intubate, you don't ventilate. That is a horrible scenario nobody wants to deal with. So we need to think about that so they don't reach that situation, right? Because physiological reserve is so small. Now, this scenario, I don't intubate, I don't ventilate. It deteriorates in a matter of minutes for a kid that very quickly moves on to a stoppage. It's not a scenario that has a time for a procedure. You're going to have a kid that has breathing arrest. So let's hope there's somebody that knows how to do it, because to have an approach with a very small child who has that experience, just surgeons. So the chance of us complicating things and having a complication if you never did so, because it's very long, so it's difficult. Yeah. Let's see at the QA. Marcelo Ramos, it's not 2000 anymore when we had supraglottics for generation supraglottics. Is there any justification for us to continue to use supraglottics, generational supraglottics in 2024, especially in pediatrics? Pediatric extension is very important. Wouldn't it be better to standardize second gen as a default? Thanks, Marcelo, for your question. Well, no doubts. You have the second generation supraglottic with the orifice, the gastric orifice available. The first attempt was to be through that one, through the possibility to base ourselves on that. So when we created the recommendations, we know that this is not the Brazilian reality, because supraglottic, second generation supraglottic, So the cost is much higher relating to others. Difficult doesn't, it's not everywhere. I work in a private hospital and in a public hospital. They're very different realities. So we wanted to call attention to recommendations is that the important thing is to try to rescue as a supraglottic. So you must, what is you have available? So if you have no condition, having two different types, it's important because you can modify strategy. If you have a supraglottic, second generation supraglottic, that may be your choice. But our goal might be is that, right? Not get rid of possibilities. Because that's, there's different realities, you know? The experience with a high flow catheter on pediatric population. Garcia and Barnes. The two questions are regarding high flow catheters. They, the childhood hospital Sambara, we use high flow on the ICU a lot. A few airway patients, they have the RCAF. Those kids that have on the airways, epiglotoplasties, laryngotracheoplasties, these kids have these catheter, but we don't utilize for the typical airway pediatric. Because even in a private hospital, we still have a limitation relating to the operators. And even then, we have a limitation of the resources in the surgical center. We actually have implemented their usage in a few situations, but we still do not have this authorization, a full authorization. So it's restricted to a few situations, but it's used on kids, mainly kids with bronchiolitis. It's been used a lot on ICUs. And these are the kids that surgical children that are malformed airways. So it's used a lot. Pedro, good evening. Congratulations on the class. In a failure situation on the first attempt, with a curved blade in kids younger than 2 years, the straight blade must be an option to be considered, even if we have lesser experience and a lesser proficiency with the straight blade. Okay, Pedro, so thank you for your question. Good question. Oh, a lot of interns on Sabra Hospital. In a general manner of speaking, for blade, we always repeat the right blade for kids below 2 years of age are a straight blade. So when it comes to the curved blade, it doesn't exist for kids below 2 years of age. The tongue has an insertion that's more posterior, it's larger, it occupies a larger amount of the oral cavity, has a triangulation on the base of the tongue with the glottis. And if we have this with a curved blade, anybody who's tried it has already seen it. Laryngoscopy, think about the tongue and the tongue falls in front. Why? Because it's very large and we don't think about the space to accommodate. It falls in front of the blade. This great blade does not even have space to accommodate the tongue. The tip of the tongue, and it does not have that anterior posterior maneuver. We have the curve, stays on the tip of the tongue and it goes down out of the molecule, and it depends on the visualization of glottis. So this is the strategy, because this straight blade, it practically smashes the tongue on that space with this hypoplastia. So ideally, we'll always utilize the first attempt, the best quality, best quality, would be to have the straight blade. So that's what we see with all the pediatric guidelines. It's the recommendation that if we switch it for the straight blade. So if we switch it for the straight blade, the lack of success ideally will have the first good attempt. So it's nice if that we train usage of a straight blade. Just let's try it on the younger kids so that later on it will be easier. Sorry, the older children, you train on the older children so that with the younger children it will be easier. So it's interesting how over the years we lost this type of training, right, Dr. Norma? We said that most of the residents that get to Sabra Hospital, they do not intubate with a straight blade. They don't do so with children. It's very important. I think that in the same way that the positioning of the airway or the mask ventilation, the strategy of the laryngoscopy with the straight blade must be points that we must always repeat this when it comes to practical training. Another thing that you brought up.
Ventilação com máscara, né? Ensinando a... Porque não é colocar a máscara e aí você faz a criança...
And then the child is obstructed. So they must do the right maneuver because it really is something that will save lives. I always say this, if you know how to perform the maneuver or provide ventilation for the child, you evolve 50% of your anesthesia is one. The child will not desaturate. It's a great thing. So a lot of people forget that you can't see anything. You need to forget about the tongue position. So forget about the cushion. Paulo Sergio Pinheiro Guimarães, what is the opinion of Professor Débora regarding the larynx tube? Do you consider it a resource better than larynx masks? Night, Paulo, thank you for your question. I'm not familiar with the larynx tube for kids. I have not experienced with the usage of this. And everything that we read, the resource is the larynx mask, and in pediatrics, you have this mask that is a mask that is used for fibroscopy and intubation. These resources for us to rescue ventilation and try to intubate through the device makes it so that this device becomes always the one that is preferred. So I have no experience. Maybe it's an interesting resource in the pre-hospital situation that we know that in fact it's easy passage in the pre-hospital works. So in the environment, I think the larynx mask, it cannot be beat. I think so. Bruna Minomi, I think I like to know what practical techniques we use to separate the progression of the tube progression with the video laryngoscope, hyperangular video laryngoscope. Is R4 R4? With the class, y'all earned some points watching class, and Pedro is our R3. It's an R3 guy. Where you want to point as well. So Bruninha has several techniques. A few techniques for repositioning. A lot of the time, the trend for us to have the closer video, when we have a centralized image, go down the tube, then it hits below, hits above, it doesn't pass. The strategy is to position yourself a bit more ahead or behind, maybe, so that you have a more widespread image so that you can see the edge and you can angulate. And another strategy is to associate devices. So you basically focus on the ones you go down the tube with the rover. So then you pass the tube through it, or when you go to use the one without the channel, you'll see the curve of the tube just like the one of the blade that we will reach the same position of visualization. So we have the air track. If you position it correctly on the right position, you'll have a hard time. You need to be a bit before it if you can, so you to have the progression more easily. Any of these works assess pre-medication and the increase of the difficult airway, non-anticipated airway. Pre-medication and increase of the difficult airways.
O que tem são alguns estudos que comparam o acesso da via aérea difícil antecipada.
The access of the difficult airway anticipated for sedation doesn't show the difference. Now, the use of the premedication with the difficult airway, well, there's no relation. They assess the risk factors for difficult airway with the difficult airway. The age below 1 year of age, the weight percentage, it's anticipated. I don't remember that. Viviane Alberdaria, she asks, Débora, how do you perform apneic oxygenation on kids? For this apneic oxygenation that they recommend today, we can utilize the nasal catheter for that high flow, 0.2 liters per kilo per minute. And older kids, 2 liters of nasal catheter. Can use the nasal pharynx. You can use the nasal pharynx. The flow must be reduced a lot. We need to remember that the high flow can have a gastric distension. So if we pass on the nasal pharynx, we use half a liter at most per minute and a lower flow. And there's also a technique that is described in a few articles, which is pretty interesting. It's the laryngoscope blade, and it places the catheter on the corner of the blade with low flow, and then you have the laryngoscopy. That flow will appear on the airway. And back in the day, we used to have a blade. I think there was a blade that had an entrance to the oxygen. It was, and we put oxygen. I've never seen that. I don't know if we have that device still. The thing is to have a catheter, right? Keep it close to the pharynx. Clarice, especially the person that is intubating is somebody that is in training. The oxygenation, same time, you know, for the larynx. There's some work being shown as well, you know, showing the time for people that did not have the time. They, residents, they don't have that much training. It does not increase the time to facilitate intubation. The tube dance technique is applicable? Tube dance technique? No, I don't know what that is. You got me. I don't know what that is. Venus Garcia. I know several dances, but I don't know that dance. Maybe it's turning it around. Venus, tell us what that is, please. Can you? I don't know what that is. Is that what would it be when you turn it around? When you twist the tube? The pediatric anesthesiologists, they always turn around because the tube, because if you have like a what would be the higher diameter superior, so I turn around so it goes above and not below. That it's It applies to facilitate the progression of the tube with hyperangulated blades. Okay. Hyperangulated blades. I don't know what to, I don't know. Maybe it's applicable. I don't know. Maybe. I don't know. I'm thinking about making the cannula turn. Do you know that, Andre? Nope, I do not know it. All I know is turn around. I just know the turning it around. It's likely that exact same method. It's a different nomenclature. Yeah, it's an alternative naming. Yeah, that's what I know. I imagine that's it. Professor, I'm gonna answer you later, Linus. I'm gonna look into that. Probably. Professor Norma, can I ask you something? Sure. Sorry to interrupt first off. Congrats, Deborah, for your great presentation. Great presentation, great revision for us. It's great. It's we wanted to watch class.
Consenso europeu que foi
My
publicado.
question is regarding the last European consensus. It was published in January 2024.
Se eu não me engano, o primeiro autor é o professor Nicola Disma.
Professor Nicola Disma.
Em relação ao nosso
and relating to our consensus,
mas que obviamente não teve acesso às informações que eles publicaram no europeu.
Was there any difference? Is it possible to apply it in our reality or not? The principle is basically the main same recommendations. That's a good question. Sometimes we get our recommendations, our consensus. They are very similar relating to recommendations. In a general manner, recommendations are pretty similar. There are two recommendations. We're publishing that recommendations, you know, Deborah, we saw, and there was no, we actually wrote down a paragraph, but there was nothing new, you know. The consensus, we would add the direct link of the European consensus. The same, I observed the same recommendations. It's great, right? Oh, Waynes was thankful. Marcelo Ramos is asking, what is your experience with air track with small children? Is it better than non-intubated ones? Marcelo, the first device, the first video that was standardized was the air track. It was the first one that was available. Oh, for many years we've had air track. So what happens? You have proficiency with air track. They see it on a monitor to teach you. Everything's great. Here we have other devices that are not the cannulated ones. And the small kids, very young babies, we use the air track due to the size of the blade or the fiber or fiber intubation. But one that is most used in the service is the air track. No, today we have an arsenal of huge devices that's available. We need to know how to use it well, the air track, because and when we get to the hospital, we have the other one. So the important thing is that the one that you have, we know how to use it right. So that makes the difference in the outcome, you know. Sure. Paulo Sergio Pinheiro, she is congratulating you. saying that it was great to watch your presentations. You know, Deborah? Thanks, Paulo. Thank you. I think, no, that's it. On the chat box, just congratulations. So no more questions. I think that the questions have been answered. So thank you, Deborah. I'm the one that is thankful for the opportunity. It has been great. It's great. So I'll pass to Andre. There's Plinio. He's also here. Plinio's here. Maybe Plinio wants to add anything. It's Lorena as well. Thank you. So Lorena to Plinio and Andre, and then we'll close. Okay. Lorena, I just want to thank you. Right at the end, I was at the other webinar, but I saw a very wealthy discussion. 10, 15 minutes of participation. You already learned a lot. Thank you to our great competent doctors. Oh, everything you do for us. Congrats to Andre for leading BJAN and Plinio. So it's just pride.
Obrigado.
Obrigada a você.
Plínio?
Também só para agradecer
Plinio,
imensamente.
also just want to thank you for continuing to work with the SBA. Thank you. Andre, you want to close? Do I close? No, I'll close it. Do you want to say anything? No, I just wanted to say this. It's been very good. It's been great, actually, to have these recommendations, you know, Deborah. I think that when people have these situations, which are the worst situations that we face during anesthesiology, for the anesthesiology practice, you know, difficult airway kids and, you know, the ones that we don't think will be, don't run into the airway. We wanted you to get more out of it and, you know, access it a lot. You know, that is access a lot on recommendations. Thank you, Andre. On your publication, Plinio and Andre, really think it was great. All the work that he had to translate to English and, you know, inform everybody. And thankful to you, Mel. You never let us down. Thank you so much. And thanks to all folks that watched us as well, right, Andre? All right, no, I'm thankful. I'm thankful to all of you and your audience for your attention. We had a great audience, and soon, next few days. So live was the English version as well as the Portuguese version and our YouTube web.
E vamos divulgar bastante nas redes.
We watched quite a bit, and on the networks is great class for Dr. Débora, and moderation as well. Great moderation on the side of Dr. Norma. It was an honor to have watched you and everyone. To all of you, have a great evening, and we'll see you next time. Thank you so much. Thank you. Good evening, and be seeing you.